Darcy, we've got about 24 participants. You want to go ahead and start?
Sure. Are you going to give a little introduction first and talk about the other webinars, or?
Hi. So yes. Hi everybody. Thank you so much for joining us today. This is the first in a series of webinars that URC will be hosting along with the support of USAID. To find out more of our upcoming webinar series, please check out our website, tb.academy. And to begin this webinar on the orientation to the comprehensive supportive care package for people with DRTB, I'd like to pass it along to our two hosts, Darcy Richardson and Lisa Adams.
Okay. All right, thanks very much. And I just saw a chat that it was very difficult to hear you. So if anybody else is having a problem hearing me, please let me know. Thank you. Okay, it sounds like this is working. So my name is Darcy Richardson. I was the lead consultant on this pilot project through the GH Pro mechanism, and Lisa Adams, Dr. Lisa Adams, will be joining me to present some of the results from our pilot later on. And she was our epidemiologist and is working as the associate. Well, you can introduce yourself, Lisa.
I will. Thanks.
Okay, so this webinar is, as they said, first in the series. So this is to give you the broad brush strokes of what the care package is about, what its framework is, what the rationale for producing it was, and what some of the preliminary results are from our pilot study. Okay, I'm trying to advance, but nothing is happening. Can you guys advance the slides, because it's not working on my end. Let me see if full screen will work. Oh, there we go. Okay. So the objectives are to explain the content and rationale and have you understand that, to understand the framework for the care package, and that includes 4 thematic areas and 13 elements under those areas that will be the structure for creating your very own comprehensive care package, to discuss and be familiar with the results of the pilot implementation, to know where you can find additional help for implementation in your own country, and to have information on the topics that will be covered in future webinars. Okay, now I'm having trouble again advancing the slides. Okay, there we go. So first of all, I'm going to cover the context and rationale for the care package. Can you guys advance? It's not working on my end. And before we do that, we wanted to have just a quick quiz to set the context for development of this care package. So in terms of the global treatment success for drug-resistant TB, what do you think it currently is globally on average? Just vote. You should be able to vote on your screen now, I think. I'll give you a couple of minutes. How does this work, guys?
So we're just collecting the answers of the poll right now.
Okay. Are we able to? Oh, there we are, polls. I see.
Yeah.
Polling, yes. So majority of folks have said 55%.
Very good. Well, my work here is done. Exactly. So obviously, okay, I need a slide advance, please. So obviously, the current state of DRTB control is lacking in terms of reaching our targets. Very good. Okay, glad to see that. Thank you. So you all can see that most of you are right on target, and global treatment success is 55%. So I think there are a lot of numbers on this slide. We're not going to go over all of them. I think the key points to get from this slide are that we're losing patients all along the care cascade when it comes to multi-drug resistant and RIF-resistant tuberculosis. First of all, we're losing the vast majority of cases by not diagnosing them. Only about 29% of the estimated 558,000 cases of TB, drug-resistant TB, were diagnosed in 2017. So there's a huge drop-off at the very beginning. Then, of the people we do diagnose, only about 87% of them actually start treatment. And out of that percentage, only 55 successfully complete treatment, 55%. So really that last number, this treatment success rate, is the one that we're hoping to improve with the comprehensive care package. You all can read the other numbers. I think that the salient points are that proportions of drug-resistant cases amongst both new and retreatment cases are increasing. And the vast majority of the burden, about half of it, is contained in only 3 countries, India, China, and Russia. So those are the countries where we're most interested in trying to implement some sort of care package to help complete treatment more successfully. And in China and India, we have a lot of gap between the treatment enrollment and the incidence. So that's what we're looking at in terms of drop-off. Next slide, please. And Biru, you will get these slides later. Can I have the next slide? Thanks. So this project was part of the National Action Plan for Combating Multi-Drug Resistant TB that was issued by the Obama White House in 2015, involving a number of US government agencies, USAID being the lead on some of the components of the strategy, especially when we're talking about the international component. So there were 3 goals of this project: was to control and improve MDR domestically speaking. Then the second goal was to improve multi-drug resistant TB expertise and control internationally. And the third goal had to do research. So we're really working under the second goal. Next slide, please. The objective under which this package was put together is objective 2.2, and there's a sub-objective there about enhancing adherence to treatment and success through providing ancillary care to patients who have TB. So all of the things that aren't directly related to delivering medications to patients in terms of providing them with drugs are included in this care package concept. And that's how we created the framework and developed the pilot. Next slide, please. Can I get the next? Oh, there we go. Okay. So just in summary, why do we need a package of supportive care for people who have drug-resistant tuberculosis? First of all, we have an increasing number of patients, and we still aren't doing very well at getting the current patients through treatment to success. So we need to do better. And to do that, we're trying to help them with all of the related challenges to MDR treatment, both the medical challenges and the non-medical challenges. And we developed this framework to also try to help define more clearly what we mean when we say patient-centered care. What does that really entail? And we wanted to create a standardized approach to looking at that, so we could create supportive interventions to address the needs of patients and reduce the costs of doing so, and eventually improving cure, obviously. And finally, because we really owe it to our patients to use the best practices and adhere to ethical standards for healthcare. And in summary, again, what are we aiming to achieve? Well, we want to improve access to treatment support, particularly to the psychosocial services that help people complete treatment. And I'll explain a little more about that. Improving treatment outcomes, obviously, is our goal, and all of that contributes to preventing suffering and death and reducing transmission of drug-resistant TB. And I want to make the point very clearly that when we're talking about quality care for people with drug-resistant tuberculosis, or with tuberculosis for that matter, supportive care until cure is only one component of that. And it looks like this slide got cut off, actually, but there are many different elements of quality care, starting from preventing drug-resistant tuberculosis to controlling transmission, diagnosing it rapidly, having well-trained clinicians to provide services to patients, giving them free, high-quality drugs, monitoring them before, during, and after treatment, providing supportive care until cure. And I think what cut off at the bottom of this is follow-up after cure. So we're really focusing only on this one component of what I would call overall quality care for people with TB. Next slide. Okay, so now we're just going to go quickly through the actual framework for the care package. And I just want to say that we did quite extensive research when we put together this package and thought about the elements. And we did online surveys, we did interviews, we did group discussions, we reviewed the literature, and we consulted a lot of different stakeholder groups. I think first and foremost, we consulted with patients who had gone through the experience of having MDR-TB and being treated, frontline providers, implementing partners, national TB programs, the donors, the literature, and global guidance documents to try to come up with something that would be adaptable and flexible and meet everyone's needs. And I just want to cover a few of the key points that came out of some of that work. Next slide. When we talked to patients and we did an online survey, we asked them to tell us what really helped them complete treatment and what was difficult in terms of completing treatment. So there are no real surprises when we look at the barriers to completing treatment. Treatment's very long. The medicine was making people feel sick. The injections were painful. They had other priorities. They needed to work to support their families, and they felt very isolated. I think the interesting thing here is when we asked them what was most helpful, you see that all of the answers to that question really had to do with their connection and support from other people and their own motivation to get better. So the psychosocial components of care are incredibly important to helping people through treatment. Next slide. So we also asked patients to make recommendations or give advice to NTPs on what was most important for NTPs to implement to help them get through care. The first thing was treatment literacy. They wanted to know more about their disease. They wanted their family to understand the disease, and they wanted to understand how to prevent other family members from becoming sick. And along with that, counseling to reduce the fear and stigma around tuberculosis was very important for patients. The top third recommendation from patients was to make financial support or social insurance available to reduce the financial burden on the family. And then helping them deal with isolation through creation of peer support groups, involving them in decision making. So having a strong focus on patient autonomy. And finally, where's number 6? To treat people with respect. So those are the things that patients are really interested